organizations. Now, I like to highlight on evaluation of thyroid nodule, a practical approach. As you all know, the Bangladesh has one of the highest number of patients with thyroid disorder. Not only nodule, almost all type of thyroid disorders are very common in Bangladesh. So we have to be very much cautious. We have to be very much responsible of treating all the conditions. So my part is thyroid disorder. Now I start with the case scenario. Probably this is a very known case scenario to all physicians, and not only physicians, all other persons as well. A 55-year Muslim woman referred from a GP to any of the endocrinologists. The lady has swelling in front of her neck over the last 9 years. So it is very slow growing one, but he did not have any other problems. But occasionally he experienced that dysphagia for swallowing the solid foods only. He did not have any weight loss, voice change, or other relative conditions that can have the sharing the scenario of the patients. So keeping all these minds, all this information in the mind, I like to start the presentation. So the presentation will end how we can evaluate. So I am starting with the nodule as a whole with a brief background descriptions. A thyroid nodule is a discrete lesion distinct from the surrounding thyroid parenchyma. This is not the usual thyroid parenchyma. It is a different one. An enlargement of other nearby anatomic structures such as the parathyroid gland or regional lymph nodes, as well as bronchial cleft and thyroglossal duct cyst may sometimes be confused with thyroid nodules. So we should be very much cautious. Thyroid mass nodules may be palpable at presentation or may be incidentally detected during an imaging procedure. Around 40% are self-identified by the patient or patient's relatives. 30% are physician identified, and 30% are incidentally discovered on imaging for other conditions. Approximately 60% of adults harbor one or more thyroid nodules. This is not similar in the all parts of the world. The highest incidence have been reported from the regions of iodine deficient area. The possibility of cancer is the overriding concern, because around 50% of the nodule might have cancer. Again, this is not similar from all parts of the world. The widespread use of diagnostic imaging and improved access to healthcare favor the discovery of small subclinical nodules and small papillary cancers, as we are also having these facilities nowadays. Overdiagnosis and overtreatment are associated with potentially excessive cost and non-negligible morbidity of the patient. So again, we should be very much judicious of diagnosing and treating the patient. Again, we should not miss any of the conditions of the non-thyroidal nodular diseases. So what are these nodules and incidental one? The discrete lesion within the thyroid gland, again, it is not a normal thyroid gland parenchyma, and radiologically distinct from the surrounding thyroid parenchyma. The parenchyma cannot be identified by palpation or by inspection. And insulinoma, as I have shown the prevalence in non-palpable nodules that has been missed by palpation or inspection, and that has been found by ultrasonography and detected by ultrasonography and imaging studies. Though usually we are doing ultrasonography, but some other imaging studies can be deployed for this one. Why the patient is having thyromegaly or thyroid gland enlargement? The thyroid nodular disease comprises of a wide range of disorders. Colloid nodules, this is typical of endemic colloid goiters. Cyst and thyroiditis comprises 80% of the cases, whereas benign follicular neoplasm and thyroid carcinoma accounts for 10 to 15% and 5% cases respectively. As I also shown that this on average this may be 5% of thyroid malignancy. So what are the benign conditions that can cause thyromegaly? This Hashimoto thyroiditis, very common globally. Colloid adenomas, common in the iodine deficient areas. cyst common in all parts of the world, follicular adenomas and Hurthol cell adenomas, not very common, but can be found in many parts of the world. And the malignant causes, the papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma, anaplastic thyroid carcinoma, primary thyroid lymphoma, metastatic carcinoma from the breast, lung, renal, head, and neck. Now, what are the importance of the thyroid nodule? As I shown that on an average 5% ranging from 7 to 15% might have a thyroid malignancy among the thyroid nodule patients. Incidence has tripled in recent years. We can refer one reference from US population. 79,000 new cases detected yearly in 2021. This was very low in 2009. It was 37,200 only. And the papillary thyroid cancer will become the third most common cancer in women by 2019, and at the cost of around 19 to 20 billion US dollar per year. So again, coming back to case, how we can evaluate the patients. Any condition, medical condition, evaluation should start with the elaborate history, and elaborate history should comprise of the general history and the system-specific history taking of the patient. Now, examination, the physical examination, especially for the thyroid nodule, very much pertinent, and the experienced hands are needed for the exact location and characterization of the thyroid nodule. Then we can go for lab investigations. Clinical factors increasing the likelihood of the thyroid malignancy. So these points should be kept in mind of the physician while practicing as a thyroid specialist or any GP who are treating the patients with thyroid nodule. There is a strong association with the family history of thyroid malignancy, and very elderly and very young patient have the highest chances of thyroid malignancy, and male has the very propensity to have thyroid malignancy. History of head, neck irradiation in early ages, infancy, childhood, and adolescence, and large nodule, especially more than 4 centimeters in diameter and partially cystic. The cystic, the nodularity and cystic pattern are highly suspicious. And if the nodule has pain. Now, the rapid growing nodules also have the very high chances of malignant potentiality. Firm to hard nodule in consistency, who are fixed to the underlying structures, and compression symptoms like dysphagia, dyspnea, or vocal cord paralysis. Many of the patients may come with these symptoms, and regional lymphadenopathy. So the lymphadenopathy may be very inflammatory or infective in nature, but we should be very much cautious to exclude the thyroid malignancy. And the growth during patients who are receiving levothyroxine therapy for hypothyroidism. Now, initial laboratory investigation, this is the thyroid trophing. Discovery of thyroid nodule more than 1 centimeter in diameter. This statement is the statement of the American Thyroid Association. And to make it clear, if the patient is having 2, 3, or 4, or several nodules having more than 1 centimeter diameter, so we should go for FNAC for every nodule more than 1 centimeter in diameter. Otherwise, we may miss the malignant nodule. And TSA should be done for those patients. Again, if TSA is subnormal, radionuclide thyroid scan can be done in many of the centers in Bangladesh. We can do this one. If the hyper-functioning thyroid nodule are present, then evaluate for hyperthyroidism. If nodularity or variable pattern, this may be non-functioning or normal thyroid gland, ultrasonogram is one of the best tool to do. If the TSA is normal or high, increased risk of malignancy we should keep again in mind. For those patients, we should go for ultrasonography. And ultrasonography is the most initial one for the evaluating the thyroid nodule for any patient. And the thyroid sonography with survey of the cervical lymph nodes can have the suspected thyroid nodule can be identified, nodular goiter can be identified in incidentuloma, and we can show one data from our nearby India in the Mumbai city. Among the patients who did not have any palpable nodule in their thyroid gland, in the thyroid, among them more than 5% had thyromegaly found by ultrasonography. And if the ultrasonography incidental is found, then we can also look for the CT, MRI, or PET scan. And low TSH in home radionuclide thyroid scan suggesting normal functioning nodules. So for those patients, the ultrasound guided FNAC for decision making. And if multiple thyroid gland, I told that if multiple thyroid gland having the diameter of more than 1 centimeter, every nodule should be evaluated. And what should we expect from the sonography? What are the patterns in the malignancy? High suspicion, this is more than 70 to 90%. Intermediate suspicion, 10 to 20%. Low suspicion, 5 to 10%. Very low, less than 3%. And benign, less than 1% by ultrasonogram. And the description of this one, high suspicion, I'm not going in details, intermediate suspicion, and low suspicion. But again, we should be very much oriented to the description given by the ultrasonographic reports of the patient, so that we can go for appropriate decision making for the pattern of the disease. Now, these are the photographs supplied by the ultrasonography or the radiologist with the reports. Now, ultrasound features of cervical lymph nodes predictive of malignant involvement. Very important. We should start from the palpation and ultimately from ultrasonography findings of the cervical lymph node. If it is more than 8 to 10 millimeter in smaller diameter, the microcalcification should be looked for. So cystic aspect should be looked for. Peripheral vascularity again should be looked for. Hyperechogenicity should be looked for, and round shape. And next step, diagnostic FNA. It is a common pattern of thyroid malignancy diagnosis. The FNA should be performed in the following sonographic patterns, and the nodular size, if the macro cancer less than 1 centimeter, often have indolent course. So again, this can be made the patient should look for the follow-up FNA. But the sonography pattern, the high suspicion recommended for FNA more than 1 centimeter, intermediate suspicion from the previous slide I showed that the recommended to FNA if more than 1 centimeter, low suspicion if the size is more than 1.5 centimeter, and if the sonography pattern is very low suspicion, consider FNA if the size of the nodule more than 2 centimeter. Observation without FNA if low suspicion is irresponsible for options, and if the benign pattern from the sonographic finding, we should not go for any biopsy for this time. FNA is of the suspicious lymph node should be performed for cytology and wash out for TG measurement if indicated. Now, interpretation, this is the globally accepted, the Bethesda system classification of thyroid FNA results. The non-diagnostic unsatisfactory if the malignancy risk predicted by Bethesda system 1 to 4 and actual risk is 20%. Benign 0 to 3 and actual risk is 2.5%. Atypia of undermined significance by ultrasonography is 5 to 15%, and the actual risk is 14%. Follicular neoplasm or suspicion for a follicular neoplasm, this is Bethesda system percentage 15 to 30 and actual 25%. And suspicion of malignancy if the malignancy is by Bethesda system 60 to 75% and actual risk is 70%. Malignant, this is 97 to 99% and actual risk is 99%. So the very confidently we can group the patient of having any risk of malignancy or current malignancy diagnosis. Now, further investigations option for intermediate nodules. This is the molecular testing. Very commonly, we are not practicing in our countries. And we can repeat FNA. Usually it is done after 3 months, and yields adequate results by 60 to 80% cases after 3 months. And diagnostic excision, this can be done for any suspicious condition, because we cannot keep the patient awaiting for many months with suspicion of malignancy. And the thyromegaly, total or partial, can also be done. The molecular testing, 7-gene panel for genetic mutation and rearrangement. Again, it is not usually practiced in Bangladesh. We have to go for testing this, sending this sample to abroad. BRAF, RAS, RET, PTC, and PAX8 and PPARY. This can be done. And this gene expression classifier also can be done by mRNA expression of 167 gene. Sorry. Now, immunohistochemistry, again, not in very common practice. In many other countries, oil-facilitated healthcare countries can also, we are usually doing for immunohistochemistry, like Singapore. The galectin-3, they are testing for the malignancy of thyroid gland. Recommendation for other investigation modalities: thyroglobulin measurements, serum calcitonin, PET scan, CT scan or MRI, and low volume lobe studies. Sorry, thyroglobulin not recommended for diagnosis. Serum calcitonin, controversy still exists, so may be done if medullary thyroid carcinoma is suspected only. PET scan not recommended for newly detected thyroid nodule, and FNAC is recommended if focal uptake of insulinoma only, followed by ultrasonography measurement. And CT scan or MRI for existing disease and staging purpose, so initially it is not advised. Low volume lobe studies if airway obstructions are observed in the patient with thyromegaly. Now, the management. So we have evaluated the patient. Now we are going for the managing the patient. Depends upon the category of thyroid malignancy. If the benign nodules are confirmedly diagnosed, follow up with ultrasonogram of the neck. If high suspicion, follow up by next 3 months to 1 year. Intermediate or low suspicion, follow up by 1 to 2 years. Very low suspicion, the follow up will be done after 2 years. If larger nodules have been found more than 4 centimeters with compression or structural symptoms, so this is for this patient, straight away we're going to go for surgery. If the cystic nature is found, then aspiration or surgery or ethanol injection of the cyst for compressive symptoms or cosmetic concern. But the ethanol is not very comfortable one, and there is every chance of recurrence. If iodine deficient area, many of parts of Bangladesh is also now in iodine deficient area. Some parts are iodine sufficient area. For those one, iodine replacement is indicated. Routine TSA suppression is not recommended in a patient with thyromegaly. This is the older approach. This is not now recommended. Intermediate cytology, if the diagnosis or review specimen with history, clinical examination, and ultrasonography very soon. If repeat FNAC done, then it can also, if the suspicion is still persisting, so we can go for molecular markers as I shown earlier. The patient preference, and after the counseling of the patient and the current scenario, we can go for final decision. Then the lobectomy, followed by either one table frozen section biopsy, and if malignant, near total thyroidectomy should be done, or if biopsy is done, if malignant, near total thyroidectomy is the option of surgery. The total thyroidectomy for high risk cases, this decision should be done by the neck surgeon, head neck surgeon, or ENT surgeons. Management of malignancy, again, surgery is the best option. After surgery, you are doing usually total or near total thyroidectomy, neck dissection for lymph node involvement, and lobectomy if small unifocal intrathyroidal carcinomas in the absence of prior head and neck radiation, or familial thyroid carcinoma or clinically detected cervical nodal metastasis. For those patients, lobectomy can be performed. And additional measures should be done, the voice assessment and parathyroid management. Philojamin sir is there and other seniors who are practicing in our country as endocrinologists. We have experienced that many of the patients with the thyroid surgery coming back with the parathyroid, loss of parathyroid gland. This is the management of the hypoparathyroidism due to parathyroid thyroid surgery, and losing the parathyroid is difficult in many of the cases. And post-operative care, voice reassessment and formal laryngeal examination if abnormality found, histopathologic evaluation of the thyroidectomy samples, post-operative staging using AJCC or UICC TNM system. This is again the common practice. Risk stratification of the persistent or recurrent diseases. If the high risk, intermediate risk, or low risk is found, then according to the risk factors, we should go for next step for the management of the patient. And indications for active surveillance as alternative to immediate surgery. If very low risk tumor like papillary microcarcinomas without clinically evident metastasis or local invasion and no convincing cytology evidence of aggressive diseases, combined conditions or short lifespan deferring surgery, for especially very elderly patients, and concurrent medical or surgical issues that need to be addressed prior to therapy. Any other emergency conditions are currently present in the patient, so we should meet up this emergency. Then after settling this one, we can assess this patient and go for a final decision making. So post-operative surveillance options, what are these? Clinical examination, history taking, thyroid function test. This is FT4 and TSH, and ultrasonography of the neck. Serum TG should reach nadir within 3 to 4 weeks, and radioiodine uptake test of whole body and whole body scan by 130 to 23 radioactive iodine, or low activity 131 radioactive iodine. Other SPECT CT can be done. FDG SPECT can also be done, and MRI also done in many of the cases. Post-operative management options are TSH suppression. For high-risk patient, the target is less than 0.1 milli-unit per liter. Intermediate risk patient for 0.1 to 0.5 milli-unit per liter, and low-risk patient 0.5 to 2. Radioiodine ablation recommended for remnant ablation therapy for persistent disease, as adjuvant therapy for intermediate and high-risk patients, and local, regional, and distant metastasis if found, then for those patients, radioiodine ablation should be done. So the prerequisite of radioiodine ablation, the counseling of specific for the patient, especially for the women of childbearing age, exclusion of pregnancy should also be made. Low iodine diet, so for those patients, high iodine diet should be prescribed. Levothyroxine therapy should be withdrawn 3 to 4 weeks prior to radioiodine therapy. TSH should be above 30 milli-unit per liter. And RH-TSH stimulation is an acceptable alteration. In few of the cases in Bangladesh also have been given. And those activity usually 30 millicurie to more than 150 millicurie is in certain situations. This is this calculation is done by the radioiodine expert, the Atomic Energy Commission people. A post-therapy WBS with or without SPECT CT is recommended for 3 to 7 days after radioiodine ablation. So there are a few complications of radioiodine therapy. The acute transient side effects are nausea, thyroidinitis, and loss of taste. Radiation thyroiditis also found in few of the cases. Gerotomia, lacrimal duct obstruction also found in 5 to 10% of the cases. Radiation fibrosis of the thyroid gland also has been reported. Transient ovarian failure or transient inhibition of the spermatogenesis may also be found in many of the cases. So After having this therapy, at least 6 months should be waited before going for fertility. Now, the mild pancytopenia immediate after the radioiodine therapy can also be noticed. Now, response to therapy, what are the definitions? Excellent response. The negative imaging and either suppressed TG less than 0.2 nanogram per milliliter or TSA stimulated TG less than 1 nanogram per milliliter. Biochemical incomplete response, negative imaging and suppressed TG more than 1 nanogram per milliliter or stimulated TG more than 10 nanogram per milliliter or rising anti-TG antibody levels. Structural incomplete response, the structural functional evidence of disease with any TG level with or without anti-TG antibodies. And indeterminate response, non-specific findings on imaging studies, faint uptake in thyroid bed on radioiodine scanning, non-stimulated TG detectable but less than 1 nanogram per milliliter, stimulated TG detected but less than 10 nanogram per milliliter or anti-TG antibodies stable or declining in absence of structural or functional thyroid disease. Now, response of the to the therapy, the categories are excellent response, the disease in the intensity and frequency of follow-up and the degree of TSA suppression, and biochemical incomplete response, the continue observation with ongoing TSA suppression and additional investigation and the therapies if needed. Structural incomplete response, the additional treatment and observation should be done. Intermediate response, continued observation with appropriate serial imaging of the non-specific lesions and serum TG monitoring. If suspicion over time is still persisting, imaging and biopsy should be done. Now, follow-up protocol after therapy. Post-ablation total body scan, no evidence of any lesion. So 3-month follow-up on levothyroxine, TSH, TG, FT3, and neck ultrasonography. If no evidence of the disease is found, then next to 6 to 12 months. And if undetectable TG or normal neck ultrasonography, decrease LT4 levothyroxine therapy yearly, and evaluate by on levothyroxine therapy by doing TSH, TG, and ultrasonogram if needed. If detectable TG and or other abnormalities, repeat RH, TSH stimulated TG at 6 to 24 months later. And if TG decreasing, so we can wait for the patient and monitor by TSH and TG. If TG is stable and increasing, withdraw levothyroxine therapy and treat with radioiodine post-therapy total body scan. Now, what are the increased risk of TSH suppression? It is not if the patient has no risk, the moderate or incomplete suppression, TSH target is less than 1. I have shown that this slide can also remind you the target of TSH suppression while treating the post-operative patients with thyroid malignancy. Now, the management of options for local, regional, and distant metastasis. The surgery is the best option. Radioiodine therapy, we can also choose for many patients, and ethanol injection and radiofrequency or laser ablation and stereotactic EBRT. Now, systemic therapy for distant metastasis should also be done for many patients. And for those patients, the kinase inhibitors, other selective therapies, conventional chemotherapies, and bisphosphonate and denosumab also all are the treatment options for those patients. So at the end, I can sum up by saying the suspected thyroid nodule and TSH normal or elevated, perform ultrasonography. If no nodule or not meeting the FNA size cutoff, so FNA not required for those patients. If ultrasonography is of high suspicion or intermediate suspicion group, and the size is more than 1 centimeter, so we should go for the FNAC. And if low suspicion and the size is more than 1.5 centimeter, FNAC should be done. If the ultrasonography suspicion level is very low, if then the size is more than 2 centimeter, we should go for FNA. And for benign pattern, no FNAC should be done. And cytological basis the category system, this is non-diagnostic. For repeat FNA, for benign, usually no surgery and other options if indicated. And if AUS or FLUS or FN by indicating suspicion of the patient, so molecular testing and repeat FNA is usually done, and diagnostic excision or thyroidectomy also be done for those patients. For malignant patient, surgery is the indicated one. So thank you for your kind attention. And at the end of the two presentation, probably we'll come back with the question and answer session.